I don't have any disclosures for this talk. So what I hope to do is to describe the modern challenges in the surgical training environment that have driven innovations in urologic education. We'll march through some of the subsets of skills, meaning open versus MIS and endourology and such, to talk about some innovations in those spaces. We'll compare surgical skills assessments. These are objective assessments on residents and how we can use them in our programs. We'll talk about the importance of feedback. We'll review talking about stressors for urology residents as a whole and how we can mitigate burnout. And no topic in 2021 cannot touch on COVID's impact on the surgical environment. And then finally, we'll, of course, touch on some innovations in our program that capture some of these points. Traditional surgical education, as we know it, really began around the turn of the 1900s. Prior to that, it was the apprenticeship model, which really had no principles at all in terms of what was supposed to be learned, what knowledge base should be acquired, even how long it should last. And it was really Halstead and Johns Hopkins in the early 1900s where we start to get the description of what we consider, those of us in the room probably, as the traditional surgical experience, which is repetitive experiences with surgical patients, learning about the scientific basis of surgical diseases, and then having graduated autonomy with increasingly complex tasks. And if that sounds familiar, it should, because that's pretty much the traditional surgical training program. But the truth is the evolution of the surgical environment over the last 2 decades really has rendered that Halstead model obsolete. And we are kind of at the tipping point here. Started in the early 2000s with the ACGME work hour restrictions. Now we have less clinical hours, yet more demands on clinical documentation and ever exploding knowledge base to learn, surgical techniques that are new and didn't exist. We also have influence from high-stake fields like aviation and the military permeating the surgical environment. You have an increasing litigious environment and also high expectations of the public on our performance. All this in the backdrop of a physician shortfall. So that increases burnout on the trainees and us. And finally, we have a new generation that has a different learning style and has different needs than maybe we did in our era. And so there needs to be new surgical training approaches that are brought to the table if we're going to develop professional and competent trainees. And the truth is that OR time is just simply too limited these days for the acquisition of basic technical skills. So we need to leverage simulators and models. And we need to deconstruct these complex surgeries into their component tasks and master them first. The days of subjectively evaluating surgical residents are over. We need objective technical assessments of their skills to facilitate constructive feedback. And we can leverage technology for that, utilizing video review. We need to address the trainee in its broader environment, the stressors on the trainee and the burnout and how that will affect their performance. We need to develop non-technical skills in our trainees to help foster professionalism and interprofessional communication. And then finally, we need to do all these innovations through servant leadership at the program level, kind of meeting the learner at their needs. So I ask you in 2021, why on earth would we start surgical training like this poor sap who's third fiddle or fourth fiddle in this case, hoping to catch a glimpse of the operative field? Maybe they get to throw a practice stitch. I mean, we have the infrastructure and the technology now to provide a better introduction to the surgical learning environment. Why wouldn't we train like this? Where you can actually do patient-specific rehearsals. You can have virtual reality or augmented reality. You can get these elaborate 3D models printed that replace cadavers. So we'll start marching through the different subsets of technical skills. We'll start with open surgery, which obviously has kind of decreased in proportion to, say, robotic surgery over the years. And the technical benchtop models that we've used or the cadaveric simulations that we've used, they're very expensive and very difficult to procure these days. So many programs have turned towards homegrown approaches, trying to leverage cost-effective models and cheaper, more available kind of materials to develop these open surgical skills. And so this is a fairly ingenious one. All it takes is go into Whole Foods and maybe your pharmacy, and you've got 2 hot dogs and a red vine and some tape, and now you've got a pretty decent, fairly high face validity model to train your junior residents on how to take down a priapism and how to do a distal shunt. So you also can leverage 3D printing. This is a full female pelvis, and you can have all the important landmarks and show how you pass a TOT sling. And here is a full male pelvis where you can teach how to do a penoscrotal approach and place an IPP. And so I think the procedures that were once relying on cadaveric models may just well be replaced by some of these 3D models, and also could be replaced by VR or AR, virtual reality or augmented reality. Or here on the left side of the screen, you see that the trainee has a superimposed view of any kind of data. It could be guiding them as to how the incision should look, but it could be medical scans. On the right side of the screen, you have virtual reality and immersive simulated experience. So this is really where the training field is heading before they hit the operating room. What about endourology? So a lot of what we do in endourology utilizes proprietary medical technologies, and a lot of these have commercial simulators that go along with them. This is the Boston Scientific Greenlight simulator, but Storz has the Atom simulator. Also, Perk Mentor is available for percutaneous access for getting practice with that. So I think the point is that we have the ability to introduce the trainee before they get to the operating room. And also there are benchtop models that you can do. This is the Boston Scientific Stone Institute, which is sort of a packaged workshop. Rick and I were the first at Baylor and a couple years ago to do that in the US with Boston. But it's a skills workshop with multiple inanimate stations. This here is this really neat mold that has a collecting system in it to help trainees learn how to get percutaneous access. And this C-arm isn't really a C-arm, it's kind of an analog camera that produces C-arm-like images. And so it's really neat. And there are multiple stations set up at these training courses. This is Dr. Link at demoing one of the VR attachments now. So now you got virtual reality to an inanimate model that we were trialing. So you can also hold your own workshops. This is something that we did with the support of Cook and Storz, where we had just simply pig kidneys and pig flanks. That's a lot cheaper than a live animal lab. And we were doing endoscopic procedures, and here you can see Rick teaching percutaneous access. So all of these things you have available in your programs. What about MIS training? I think we all know that, as Rick touched on, laparoscopic surgery is relatively diminishing in the face of exploding robotic volume. So we need to replace that volume by getting experience outside the operating room with simulations, or programs like FLS, Fundamentals of Laparoscopic Surgery, which is a web-based curriculum that has modular content, basics of physiology, but it also has a skills assessment attached to it. And there are lots of dry lab simulations that have been published for both basic skills and even procedure-specific skills. Rick and I did that with the AUA for a pyeloplasty model. So these things are all out there and published. And then, of course, you have the simulators, the DV trainer, which we've published on at Baylor, and then also the Da Vinci Skills Simulator. So what do you do about, you have a patient who's got a complex endophytic mass, and I want my chief resident to try to do this procedure. Well, you can start leveraging other technologies. This is sort of an immersive experience where you can upload the image and get this three-dimensional understanding of how the mass is associated with a collecting system and other great vessels. And then you can go one step further. You can actually print a patient-specific model. This is through 3D Lazarus, who just got their FDA clearance for this technology. But you can use it as a patient education tool if you'd like, but what we do is use it as training. And you'll hear a conversation with my resident and I as they're reflecting on what are they doing. How wide do you think you need to go there?
I don't need to go wide. I already just had made it, so I realized that I really need to be like...
So he's reflecting, I didn't need to go that wide.
I think I ended up going a lot wider than I needed.
Yeah, on the left side, right?
Yeah.
On the head side.
So see how specific that is? See how clear? There's no assumptions. We're communicating completely. You went too high on that side. You went too high on the left side. And now you can also see landmarks. Here's renal sinus fat, and he's going to be able to anchor that because we all know it doesn't, we all know it doesn't look like that. You know, this is what it actually looks like. This is the actual procedure, and it's bleeding, it turns out. And so he has some level of confidence because he's done it twice before, and he sees renal sinus fat, and he has his landmarks. So that just gives him great confidence and gives me entrustability to let him continue to struggle and proceed in what, you know, was a difficult resection. But it can be helpful for us too. So this, you know, I would say is a bit of a challenging partial nephrectomy and not the best place in the world. Can it be done, or in Rick's words, should it be done? But I think if you really want to know that, then why not take it to the next step? Why not get a 3D modeling of it, understand how it is really in relationship to the segmental vessels and the collecting system. Go ahead and print all that out. Have them model all of it. See what it looks like as you cut this thing out. Maybe cut it out once. Oh, I went a little deep there, too much normal parenchyma. Let me cut it out again. I did a little better that second time. So that way when I get to the operating room, and here you see the simulation, I can see that there's a segmental vessel at the base of my resection here. So over here, when I'm kind of in my bloody mess, I know this is all renal pelvis. And now, oh, wait a second, I'm not sure about this thing over here. Maybe that's that segmental, so I think I'll cauterize that because I remember doing that. I've rehearsed on this patient before. You could take these videos and you can review them with your residents, just like athletes review videos to help their performance. You could take the videos and put it into a conference setting where everyone can sit down and just very calmly decompress about the procedure, where it's hard to do that when you're cutting out a hilar tumor like that. And this has been studied from the Maryland group where as you might expect, you get more teaching points and more focus on teaching when you're not in the high-stress environment of the operating room. You could crowdsource your images, costs money, but you can do it. You can get some very useful feedback from that, from experts. So we put all that together in a curriculum that we do for our PGY3 residents in their MIS experience. And so they go through the fundamentals of laparoscopic surgery and the technical assessment. They also go through robotic training with the help of Dr. Jones at the VA, and they have expectations of being oriented to the robot. They have modules they need to do online. They need to watch how Rick Link does a prostate and how he does a partial before they get in the room. They need to do the simulator, and they need to do it to a certain level of proficiency and show that to us. And then in the operating room, it's purposeful. We break down the component tasks. They need to tell me how many times have they dropped the colon, how many times have they done the upper pole dissection. And this is how you bring, you know, this innovation of thinking into your modern training program. And one of the crucial components of any high-quality training program is these objective assessments, skills assessments, and probably the most widely published ones were GEARS, which is developed at Baylor here and widely published, and then OSATs, which is for open technical skills. But you could do procedure-specific skills as well. This partial nephrectomy, how does this resident do on partial nephrectomy versus prostatectomy? And you can create resident report cards. This is a lot of data to manage, and so software systems do help. My tip report is fairly robust and flexible for that. Simple is fairly simple, which is what we have utilized, and this is a smartphone application, and so it's real time, and that's so crucial for feedback, is getting real-time feedback to the trainees. And the real goal of Simple is to assess preparedness at the time of graduation in various operations, and so you do it over time. And how this works is, if I'm in your shoes, I'm thinking, oh my gosh, who's got the time to do all this? But actually, it doesn't take hardly any time. I'm going to do it for you right now. Here's a laparoscopic partial nephrectomy that I had double scrubbed residents on. So I'm going to evaluate them. First question, how much did they do autonomously in the critical portions of the procedure? You can define that. So is that the hilar dissection? Is that the tumor? And then how do they do? And then dictate some feedback. And you're done. And so that's how much time it actually takes. And so this has been studied as a pilot project with Kate Kraft's group at the University of Michigan. And they found that not only is it preferred than the traditional evaluations, but it actually makes getting feedback easier. And most felt that it did kind of accurately capture autonomy in the operating room. So this has turned into a national trial that certainly we are a part of, some fellowship, some residency, and we are very much a part of it. We're second in terms of the assessments that we've provided, to the trial. And so this is how you can get involved with educational scholarship nationally for your program. So feedback, I think that this is critical for the modern trainee. Most trainees are uncertain about their skills. Many pursue fellowships just because of a perceived technical need to do so. And the weakest spots for modern trainees seem to be robotics, percutaneous surgery, and laparoscopy. So we feel like that in order to maximize the learning opportunity of each case, that we really need to consistently and constructively evaluate the trainees and set performance goals for both that case and the next case. And this turned into an educational scholarship project that was led by Dr. Taylor, where we actually formalized this conversation. Talk about the patient, talk about what you want the trainee to do, and when you're done, talk about how it went. And so this was published in the Journal of the American College of Surgeons and selected for a manuscript from them and tweeted from them for a journal club. But ultimately what we found was that preoperatively, there was quite a bit of disparities between what we felt like we were doing in terms of pre-op conversations and goal setting and post-op debriefs and what the residents thought we were doing. But what was interesting was after the intervention, everyone was on the same page. And not only that, everyone liked it. And it didn't take any time because you roll it into the case. You do it as you time out. You do it as you close. And so I think a lot of times when you get into the space, you think, how am I going to get this instituted in my program? But it's easier than you think. And most importantly, it translates to measurable improvement in skills assessments and also meaningful change in the culture. Which brings me to the culture, just the outside the OR stressors that the trainees are dealing with, which is burnout, which is endemic in all of us, but certainly in trainees. And so we at Baylor College of Medicine, we did our own assessment on that, again, through work from Dr. Taylor. And we found that we, not surprisingly, had a lot of burnout. And so we wanted to target this. And so we came up with a very purposeful set of initiatives and implemented them. And in the interest of time, I won't go through all of them. This was published, so the citations at the bottom if you'd like to look. And we found that our initiatives led to meaningful decrease in burnout and also improvement in wellness. This is personal achievement sense. So what about COVID? COVID certainly had a dramatic effect on the educational environment. This was an SAU survey where 45% of the program directors responded, and most were responding that their residents had less clinical time. Many were concerned that they weren't going to meet their minimums. Most were using video conferencing, and what most found that these lecture series from experts across the country, which many of us at Baylor participated in the COVID lecture series, were very helpful and grew out of that. And that kind of got us thinking, with the cancellation of the visiting students not being able to come for away electives, how can we leverage this? The SAU had already convened a national task force that Mike and I served on in terms of creating a virtual sub-internship in urology. And so we just took that and ran with it for our own course here at Baylor. And what we did was we really leveraged virtual streaming, bringing the student into the operating room for live surgeries, even moderating them sometimes, answering their questions, bring them into our clinics. Mo would run around with the student and they would go interview Mo's patient, and then Mo would come pick up the laptop and they would sign out just as if the patient was, if the student was in the office. And we studied it. You'll see there's a theme here. You can have educational scholarship for your program, and that is its own engine for innovation. But there was a high level of satisfaction, and the most popular parts were the one-on-one time with the faculty members and the trainees, and also the OR streaming. So what about Twitter? I don't know much about it, but I do know that it's important for connectivity, and in the recruitment season that's all virtual, that it's very important from those perspectives. And we know that it can disseminate some learning materials. We see that informally with banks of educational videos, but what we wanted to know was, and specifically we being Dr. Kara and Dr. Popat, was could it be used as a collaborative tool to prepare, say, for the in-service? And so we studied that. Dr. Kara led an initiative where we posted online 3 to 4 open discussions a week and encouraged faculty members and trainees to respond to that and to cite literature. And what we found was that it was generating more study, more reading, and 90% of the people who participated wanted to do it again. So I think that you can leverage social media. When it comes to non-technical skills, this is extremely important in the modern environment. Many surgical incidents are actually due to non-technical skill gaps rather than technical skills gaps. So there are assessment tools that your program can utilize on how to identify gaps in your trainees. What we've done is kind of bring the holistic training, so to speak, of healthcare disparities, diversity, inclusion, and equity into our program in the forefront, again, through efforts from Dr. Taylor. And so we've had implicit bias training. We've had invited speakers come to our grand rounds. We've done dedicated journal clubs and book clubs. And this is how you can start bringing these conversations to the table. So future directions, leveraging this technology for regional collaborations. We have 4 training programs within a 30-minute radius of us, and so we are combining our efforts, having combined grand rounds, visiting professorships, even workshops we're working on moving forward. I think the national involvement is very important, keeping connected to that conversation. So we have these educational collaboratives that I'm involved in. Simple's one of them, but we have another one through the AUA about needs assessments. Staying involved with the SAU, on a task force for that currently. And then milestones, for those who don't know, were developed to help more objectively assess trainees on a semi-annual basis. Mike was the chair of the inaugural milestones, and I participated in the design of this new one. But we have to study it. It just started. It's only been out a year, so we need to study that. We need to keep our focus on the broader stressors. So congratulations, Dr. Taylor, on your grant to study resilience and prevention of burnout in our trainees, and Dr. Joni is going to be leading that charge. And then competence-based education is coming down the pipe. It's not here yet, but it's something to keep in mind. So I know I went over, but I guess the point is that new technologies drive surgical innovation, and we have gone far beyond the Halstead model at this point. And we need to have very purposeful skills assessments, objective, concise feedback and skills assessments. And we need to develop the whole trainee, not just the surgeon aspect, but the professional surgeon. And I would encourage you to really listen to your trainees to identify the gaps in your program and do needs assessments so you can bring the education to them that they need. And I hope that I've demonstrated in this talk that there's no way any of this can be done without collaboration. And so specifically, Dr. Coburn for leading the charge and leading the program for 16 years, and also having an educational slant for our program. And then Dr. Taylor, our program director, and led a lot of these initiatives with Dr. Popat, who I really credit to changing the educational culture in our program to bring us into the 21st century. And my partner in crime, who I can do nothing without, is Caroline Hubbard, who is my program coordinator for these years. So thanks so much, and we'll take any questions at the end.